So this is part B of the urinary system. We talked a little bit about filtration as kind of the first step in urine formation, and now we're in step 2, tubular reabsorption, which will quickly reclaim most of the tubular contents and return them to the blood. It's a selective transepithelial process where almost all organic nutrients will be reabsorbed back in to the systemic body blood circulation. Water and ion reabsorption is hormonally regulated and adjusted. This includes active and passive tubular reabsorption, and substances can follow two routes, either transcellular or paracellular. And again, just a reminder, this is step 2 in urine formation, and tubular reabsorption takes things out of the filtrate and puts them back into blood circulation. So, by the transcellular route, solutes will enter the apical membrane of tubule cells, travel through the cytosol, and then exit out the basolateral membrane, and then it'll enter the blood through there. The paracellular route just means that substances will be reabsorbed between tubule cells. It's limited by tight junctions, but leaky in the proximal nephron. So, water, calcium, magnesium, potassium, and some sodium in the proximal convoluted tubule move via this route. So the transcellular route kind of takes you through these 3 steps as shown here: movement through the interstitial fluid and into the capillary. And then the paracellular route just travels between cells kind of through the leaky channels. Particularly, the paracellular route functions in the proximal convoluted tubule. Sodium transport is the most abundant cation in the filtrate, and the transport of sodium across the basolateral membrane is active transport. So we have a sodium potassium ATPase that will actively pump sodium into the interstitial space, and then it's swept by bulk flow into the peritubular capillaries. Sodium will enter the tubular cell at the apical surface by secondary active transport, or a co-transport system. So we kind of have this active transport system. Secondary active transport uses an electrochemical gradient created by pumps that give a push needed for the transport of other solutes. Organic nutrients reabsorbed by secondary active transport will be co-transported with sodium, meaning they'll be transported at the same time. These will be glucose, amino acids, some vitamins, and ions. The passive tubular reabsorption of water, so the movement of sodium and other solutes creates this osmotic gradient for water. So we kind of are moving all of these solutes over to the other side, and water will be reabsorbed by osmosis because water will naturally follow an area where there's more highly concentrated sodium and other solutes. It's aided by water-filled pores called aquaporins. Obligatory water reabsorption, these are present in the proximal convoluted tubule, and then facultative water reabsorption, aquaporins, will be inserted in collecting ducts only if antidiuretic hormone is present. If you remember, antidiuretic hormone reabsorbs more water back into the bloodstream, so you urinate less, more concentrated urine, but less water out. So ADH just puts more aquaporins in. Solute concentration in the filtrate will increase as water is absorbed. It'll create this concentration gradient for solutes, which will drive their entry into the tubule cell and peritubular capillaries. Fat-soluble substances, ions, and urea will follow water into the peritubular capillaries down their concentration gradients. And for this reason, lipid-soluble drugs and environmental pollutants will be reabsorbed even though it's not desirable. You don't want lipid-soluble drugs and environmental pollutants absorbed back in. So this just shows the tubular reabsorption of water and nutrients using active and passive transport, talking about the sodium potassium pump kind of pushing the sodium out, and this creates a gradient so that water will pass through passively. So this passive transport or diffusion of water occurs through transport proteins, ion channels, or aquaporins, and other lipid-soluble substances, ions, and urea could pass through as well. The transcellular transport systems are specific and limited. Remember, this will occur when things are transported between cells. The transport maximum exists for almost every absorbed substance, so this reflects the number of carriers in the renal tubules that are available. When carriers for a solute are saturated, excess will be excreted in the urine. So, for example, hyperglycemia in the blood will lead to high blood glucose levels that exceed this transport maximum. So glucose will actually spill over and be excreted into the urine. So glucose in your urine could be a sign of diabetes. The proximal convoluted tubule is the site of most reabsorption. So this is what I want you to focus on. Mostly everything is reabsorbed back into the bloodstream in the proximal convoluted tubule. About half of urea is reabsorbed here, but later secreted back into the filtrate. The nephron loop in the descending limb, water can leave, but solutes cannot leave. So it's permeable to water, but nothing else. In the ascending limb, it's not permeable to water. So water cannot leave the filtrate, but solutes can. The thin segment is passive to sodium movement, and the thick segment has different symporters and antiporters that transport sodium into the cell. The distal convoluted tubule and collecting duct reabsorption will be hormonally regulated in these areas by antidiuretic hormone, which is released by the posterior pituitary gland. And again, that inserts aquaporins in the apical membranes, increasing water reabsorption. So an increased ADH hormone levels will cause an increase in water reabsorption, will increase your blood fluid levels, blood pressure, and decrease the amount of water excreted. So you'd be excreting out extremely concentrated urine. Aldosterone system then promotes the synthesis of apical sodium and potassium channels and basolateral ATPases for sodium reabsorption, and water will follow that. So as a result, little sodium leaves the body. So without aldosterone, daily loss of filtered sodium would be about 2%, which is incompatible with life. So the functions of aldosterone are to increase blood pressure by increasing sodium and water reabsorption and decrease potassium levels. Atrial natriuretic peptide reduces blood sodium, resulting in decreased blood volume and blood pressure. So this kind of does the opposite. ANP is released by your cardiac atrial cells if blood volume or pressure is elevated to try to reduce blood sodium, decreasing blood volume and blood pressure. And then the parathyroid hormone just acts on your distal convoluted tubule to increase calcium reabsorption. So this is just a summary of the tubular reabsorption and secretion. Probably a great chart to study, and I probably won't ask you too much outside of a chart like that. These are also great kind of summaries of what is the substances reabsorbed and the mechanism. This probably goes into even more detail that I would ask you, but this is also a great chart, and then it continues on the next slide of the substances that are reabsorbed and the mechanisms by the reabsorption of those substances. And then tubular secretion is the final step of urine filtration. So tubular secretion is reabsorption in reverse. So tubular secretion is reabsorption back into the filtrate. So think of your blood capillaries secreting ions and electrolytes back into the filtrate. And secretion occurs almost completely in the proximal convoluted tubule. Selected substances will be moved from the peritubular capillaries through the tubule out into the filtrate, like potassium, hydrogen ions, ammonium, creatinine, and organic bases. Substances are synthesized in the tubule cells, and they'll also be secreted, such as bicarbonate ion. So again, a look at what secretion is. It's things moving out of the bloodstream back into the tubule, and most of this happens in the proximal convoluted tubule. Tubular secretion is incredibly important for disposing of substances, drugs, metabolites that are bound to plasma proteins. So remember, plasma proteins can't be filtered through the glomerulus. So anything bound to a plasma protein can be disposed of through this tubular secretion. Eliminating undesirable substances that were passively reabsorbed previously, like urea and uric acid, ridding the body of excess potassium, and controlling blood pH by altering the amounts of hydrogen ions or bicarbonate in the urine. So again, a great kind of summary of tubular reabsorption and secretion in that. One of the main functions of the kidney is also to make any adjustment needed to maintain body fluid osmotic concentration at around 300 milliosmolarity. And osmolarity is just the number of solute particles per 1 kilogram of water. So think of it kind of like concentration, but a little different. The kidneys produce only small amounts of urine if the body is dehydrated or very dilute urine if it's overhydrated. So this is one regulation of volume that the kidneys, they'll make either dilute urine or concentrated urine. And they accomplish this by using the counter current mechanism, where fluid flows in opposite directions into adjacent segments of the same tubule with a hairpin turn. This counter current mechanisms, I'm not going to ask you guys too much about. Just know that the kidneys work to maintain very regulated urine concentration and gradients, but I won't ask you guys too much about this. So I'm going to kind of skip over this here. But that happens in different parts of the nephron loop, depends on different things. Again, this countercurrent multiplier, these countercurrent mechanisms, I won't ask you guys, so I apologize. I didn't take them out of the PowerPoint, but don't worry about looking at these. And we might not actually have too much more to get through because I don't want you guys to focus on that at all. All right, and then again, those whole processes lead to this formation of either dilute or concentrated urine. Overhydration produces large volumes of dilute urine. Antidiuretic hormone production will decrease, and if aldosterone is present, additional ions can be removed, causing water to be dilute. Dehydration produces small volumes of concentrated urine, so the maximal ADH will be released to try to reabsorb that sodium water back into the body. In severe dehydration, about 99% of water is reabsorbed. And that makes sense. If you haven't been drinking a lot, what color is your urine? Probably an amber, a dark yellowish type color. And if you do drink a lot of fluids, your urine is a lot lighter in color, sometimes even completely clear if you're drinking a lot of water. So here are mechanisms, again, that I kind of skipped over, but just know that your kidney can create very dilute or very concentrated urine in cases of severe dehydration. This is showing a woman in the desert, or an overhydrated, so drinking plenty. Urea recycling. Urea helps form medullary gradient, and this gradient is important for that concentration of secretion and absorption. So urea will enter the filtrate in the ascending limb by facilitated diffusion. The cortical collecting duct reabsorbs water, leaving the urea behind. And now in the deep medullary region, the highly concentrated urea will leave the collecting duct and enter the interstitial fluid of the medulla, and urea then will move back into the ascending limb. So we kind of have this urea recycling to help create this concentration osmotic gradient so that things can be passively or actively absorbed or secreted into the filtrate. A diuretic is a chemical that enhances urinary output. It will inhibit antidiuretic hormone, and alcohol is one such drug that does so. Sodium reabsorption inhibitors like caffeine or drugs for hypertension or edema will also enhance urinary output. Loop diuretics will inhibit the medullary gradient formation, and osmotic diuretics are substances not reabsorbed, so water remains high in the urine. For example, in diabetics, you have a high glucose concentration that pulls water from the body. A urinalysis is where urine is examined for signs of disease. It can also be used to test for illegal substances. Assessing renal function requires both blood and urine examination. So renal function can be assessed by measuring the nitrogenous waste in blood, and to determine how much is being cleared, we call that renal clearance. Both blood and urine are required. Renal clearance is the volume of plasma kidneys can clear of a particular substance in a given time. Renal clearance tests are used to determine the glomerular filtration rate to help detect glomerular damage and to follow the progress of renal disease. Here's the renal clearance rate and how it's calculated. I won't ask you guys to know that, but this is what renal clearance is about. Chronic renal disease is defined as an extremely low glomerular filtration rate for up to 3 months. Filtration formation will decrease, nitrogenous wastes will accumulate in the blood because they're not being excreted, and the pH of the blood can become acidic. It's seen in diabetes, mellitus patients, and also hypertension, high blood pressure patients. Renal failure is when the glomerular filtration rate is less than 15 milliliters per minute. It causes uremia, which is an ionic and hormonal imbalance, metabolic abnormalities, toxic molecular accumulation. Symptoms of this can be fatigue, anorexia, nausea, mental changes, and cramps. And a treatment is hemodialysis treatments, weekly, several times a week, or a kidney transplant. So the chemical composition of urine is mostly water, about 5% solutes. Nitrogenous wastes in it are urea, uric acid, and creatinine. Other normal solutes are found there. Abnormally high concentrations of any constituent or abnormal components like blood proteins, white blood cells, bile pigments may indicate some sort of disease or pathology. So here's abnormal urinary constituents and what the possible causes are. And it's kind of interesting to know this. Um, Maybe you won't get to this in your health field if you're not working with dialysis patients or with urinalysis patients, but chances are you or a loved one will undergo a urinalysis test at some point. The physical characteristics, it can be clear, cloudy could indicate a urinary tract infection. Pale to deep yellow could cause from urochrome, which is a pigment from hemoglobin breakdown. The yellow color deepens with increased concentration. And any abnormal color like pink, brown, or smoky could be caused by certain foods, bile pigments, blood, or drugs. The odor is slightly aromatic, if you want to call that, when fresh. It develops ammonia odor upon standing, as bacteria will metabolize the urea, and it could be altered by some drugs or vegetables. Disease could also alter the smell of your urine. Patients with diabetes may have an acetone type smell to their urine. The pH of urine, it's slightly acidic. An acidic diet could cause, a more acidic drop in urine pH. An alkaline, basic diet from vegetarians or prolonged vitamin or urinary tract infections could increase the pH. Specific gravity, you can read about there. We go through these because then they measure this on urinalysis tests. The transport, storage, and elimination of urine. The ureters convey urine from the kidneys to the bladder. Again, so we're getting a little bit more in the anatomy here. The three layers of the ureter wall are shown there. The muscularis is the smooth muscle wall that will contract to kind of squeeze the urine along. And that's the cross section of the ureter wall. Homeostatic imbalance, renal calculi or kidney stones. Large stones can block the ureter, which could obstruct urine flow, causing excruciating pain. You don't want that. Nephrolithiasis are kidney stones in the kidneys, and uterolithiasis are stones in the ureters. A lot of them pass without intervention. Some of them need to be surgically or endoscopically removed. Risk factors are obesity and elevated blood calcium levels. Then the urinary bladder, a little bit of anatomy. I'm going to let you guys review this anatomy on your own. And the muscular wall. The muscular layer, also known as the detrusor muscle, contains 3 layers of smooth muscle. And here's a look in a male structure of the urinary bladder and the urethra and how the prostate gland sits right below the bladder. In the female, the bladder and the much smaller in length urethra for the female. Urinary storage capacity, it collapses when empty. Rugae appear. It'll expand and rise superiorly during filling. And this just shows you what a moderately full bladder, about what it can hold. And there's the urinary bladder, the kidneys, and the ureter is kind of a cool, what we call pyelogram that you can see. Then the urethra is the muscular tube that drains the urinary bladder. Consists of transitional epithelium near the bladder. You have different sphincters. The internal urethral sphincter is under involuntary control, so that'll contract to open when the bladder is emptied. So the detrusor muscle is a smooth muscle under involuntary control, and that'll empty and open this internal urethral sphincter. But what you guys control is the external urethral sphincter, and that's under voluntary or skeletal muscle control. The female urethra lies there, and then the prostatic urethra, intermediate part of the urethra, and then sponge urethra in the male carries both semen and urine. And there's the structure of the urinary bladder and urethra again, between males and between females. UTIs can be caused by improper toilet habits, such as how you wipe after defecation. Most UTIs occur in sexually active women. About 40% of women get UTIs. And a lot of that's caused from intercourse, driving different bacteria more kind of closer to the bladder. Urethritis is inflammation of the urethra. Cystitis, inflammation of the bladder. You can have inflammation of the kidneys. Symptoms, the biggest one is just painful urination. If you've had a UTI, you know what that feels like. Urinary urgency, you have to pee all the time. Frequency, fever, because your body's fighting an infection, and sometimes cloudy or blood-tinged urine. Antibiotics are usually required to cure most urinary tract infections. I knew of one woman, though, who only drank cranberry juice. She got rid of it, but I think much slower. She's kind of anti-med. I would take the antibiotic if I were you. Micturition is the process of urination or voiding. Three simultaneous events occur: contraction of the detrusor muscle in the bladder, opening of the internal urethral sphincter, that all happens automatically, and then opening of the external urethral sphincter is under voluntary somatic control. Reflexive urination in infants, distension of the bladder activates stretch receptor, it leads to contraction of the detrusor and opening of the internal sphincter, and inhibition of the somatic pathways will allow its relaxing and opening. So a little bit different in infants. Control centers mature between ages 2 and 3. So that's the normal age, probably when a kid gets potty trained. Um, so it's okay to wait a while because their little nervous system might not be totally ready yet. So here's control of micturition. Urinary incontinence is usually caused by weakened pelvic muscles. So urinary incontinence means kind of leaking about urine, unable to control that external urethral sphincter. Increased intra-abdominal pressure will force urine through the external sphincter, usually through laughing, coughing, sneezing. Overflow incontinence is when urine dribbles out when the bladder overfills. These weakened pelvic muscles can be caused under general anesthesia, hypertrophy of the prostate. This is when urinary is retention. I was going to say about urinary incontinence, it can be caused by obesity, elderly, you lose some of that control, and also after pregnancy, you can have weakened pelvic floor muscles. Urinary retention then, so this is when the bladder is unable to expel urine, very common after general anesthesia or the hypertrophy of the prostate, and a treatment is just catheterization, so putting in a catheter to help empty out the bladder. Thanks for being a part of the semester, guys. I wish you the best in all your future endeavors if you listened this far, which probably most of you didn't. But thanks for listening. I wish you guys all the best, and let me know if you have any questions.